Our final speaker today is Syed Ali Husain, a transplant nephrologist at Columbia University Medical Center, where he also completed his clinical training in nephrology and in transplant nephrology. His current research focuses on kidney transplant outcomes with a focus on access to transplant and deceased donor kidney allocation. His work has been funded by the National Kidney Foundation and the Nelson Family Foundation. Dr. Husain, we look forward to a great presentation.
Thank you. And thank you to Rogers Institute and to the Vagelos Center for the invitation to speak. Here are my disclosures, nothing interesting and no conflicts of interest. And really the objective of today's talk is to basically build a case to you that providers and provider behavior play a significant and often underappreciated role in perpetuating racial disparities in access to kidney transplant. Even though kind of provider behavior on an individual level is a little bit hard to prove directly, we'll do that largely indirectly by demonstrating that disparities in access to transplant really persist even after you adjust for others and account for other systems factors that are often blamed for racial disparities in transplant access. Before we can start that, just a little bit of background knowledge for anyone who's coming from a different background that's not familiar with transplant. We can't go into this in detail, but kind of what you should know is that kidney transplant is way better than dialysis in every way. It provides better survival, better quality of life, and achieves both those at a lower cost to the payer than dialysis. Additionally, earlier transplant is better than late transplant, especially preemptive transplant that occurs before the initiation of dialysis. And living donor transplants have better outcomes and better survival than deceased donor transplants. And in fact, as you can see there on the right, 5-year patient survival after living donor transplant is more than twice that 5-year patient survival after hemodialysis. So we're really talking about big benefits compared to other therapies available for other diseases. But achieving preemptive living donor transplant requires early counseling and early referral. And potentially as a result, the last piece of background knowledge you need to know is that Black Americans are less likely than Americans of other race to be waitlisted for transplant, to get any transplant once they're listed, and to get either a preemptive transplant or a living donor transplant. So literally everything I told you that was good, Black Americans are less likely to get any of those outcomes. The other way to think about this is that there's no one choke point that's leading to these disparities. If you look at the top half of the slide and you think of kind of the process from kidney disease to transplant as a series of steps that candidates have to achieve and move on to the next one. You know, from being interested to being deemed medically suitable to continuing their workup to getting on a list and finally getting an organ. There's a disparity between Black Americans and white Americans at each one of those steps in terms of progressing to the next step. And that disparity is large. This data on the bottom you can see is from adults in Indiana, Kentucky, and Ohio from the mid-90s. You can see that even then, even among patients who are on the list, kind of getting a transplant has a disparity that's just as wide as other steps. And before we kind of blame only Indiana, Kentucky, and Ohio as kind of outlier types of states, I think we should acknowledge the fact that this disparity is really pervasive throughout the United States. So here you can see that a map of the United States dialysis centers, where blue dots represent centers without a big difference in waitlisting, and red triangles represent facilities with a large difference, racial disparity in waitlisting. And you can see that no region of the country is spared. Even places that we like to think are very diverse and progressive have tons of centers that have large racial disparities in waitlisting. And remember, this is even an underestimate because it doesn't even count patients who are preemptive, where I had already told you there's a large disparity. Even more troubling is that this disparity, in fact, is also seen when we look at international data. So this is DOPS data from 7 countries, the US, Europe, Japan. And we can see that even in this international cohort, patients who are Black race have a significantly lower relative rate of transplant compared to white patients in the same cohort. Although this is a little bit misleading, I'll admit, because predominantly the patients in this DOPS cohort who have Black race are predominantly coming from the United States. But I guess the big question is, if we're seeing such pervasive differences in access to transplant and especially in referral, why is this happening? If we ask nephrologists, we get some interesting answers. So here is a results of a survey of 278 US nephrologists about why they think there are racial differences in evaluation for transplant. So just that first step, right, getting to the evaluation phase. You can see right at the top of that list, the number one reason most likely to be cited as very important or moderately important for these disparities was differences in patient desire to have a transplant. And if you pass all these other potential explanations that are listed very commonly, so availability of living donors, not completing evaluations, a lack of social support, financial problems, expected adherence to therapy after transplantation, get past all of those, and then you get to only 1 in 8 physicians who thought that there was any physician bias, racial bias in referring. What I'd like to argue to you is that realistically, these biases are these biases impact all these subjective aspects of assessing the factors that physicians are pointing to above them. So, for example, our subconscious biases might impact who we think might have a financial problem that's too large to overcome, or who we think has adherence that's low enough to prevent them getting access to transplant. Because ultimately, if you think about it, if we say that patients' desire to have a transplant is very different among different races, what we're saying is that we believe that patients will be dramatically less likely to desire a treatment that, as I've told you, has better survival and better quality of life, which kind of should be hard for you to believe if there's adequate education about those benefits provided. In other words, if you think about this schematic, it's likely that our racial bias kind of impacts all of the aspects that we know lead to disparities in access to transplant. And in fact, patients realize this, right? So here is data from 127 patients who are undergoing kidney transplant evaluation in the mid-2000s. You can see on the left, no surprise based on what I've already told you, African-American patients were significantly less likely to get activated on the wait list after they began their evaluation, and those who did took longer to get onto the wait list after beginning evaluation. But more importantly, if you look at the right side of the screen, if we look at the predictors of time to be accepted for kidney transplant, perceived discrimination was an independent risk factor for longer time to be waitlisted. And in fact, patients who reported any perceived discrimination had half the rate of waitlisting after beginning evaluation than patients who perceived no discrimination. So if we can do a deep dive for a moment into living donor transplant as a case study, it's kind of a nice contained set of transplants to look at. So we know that there are known racial disparities in living donor transplant rates. There have been many hypothesized mechanisms I told you, including upstream disparities in access to care, financial barriers, and high comorbidities burdens among potential donors, especially first-degree relatives. And as a result, you can see there on the right that the disparities in access to living donor transplant among patients who are on the waiting list has actually continued to become more disparate over time rather than less. We recently studied this to try to get a better sense of if we could isolate specific disparities that were primarily to blame, or specific factors that were primarily to blame for this disparity. We looked at all incident waitlist activations after the rollout of the new kidney allocation system at the end of 2014. And kind of doing this allowed us to follow patients who had at least 4 years of follow-up. And by looking only at patients who made it to the active waitlist, we bypassed some of those early things. These are patients that got through referral, that got through testing, passed the selection committee, and actually made it onto the list active, and compared their rates of living kidney donation and the types of donors they received. What shouldn't surprise you from the beginning is that we found that African-American candidates were significantly less likely to receive a living donor transplant in competing risk models, even after waitlist activation. But surprisingly, these disparities continue to diverge over time. So it's not like just that these kind of disparities occurred early and then the lines became parallel. You can see that on the right, kind of the further out you got from activation on the wait list, the larger and larger the disparities became. So from this part alone, you can just conclude, okay, this is clearly not just issues of workup. Even patients who have been adequately worked up and made it to the list still have these disparities. So next we asked, okay, one of the most common things that was listed in that survey was socioeconomic status. So to look at whether socioeconomic status alone was to blame, we divided both racial groups into whether or not they were insured by Medicaid or a different payer, with the idea that we know from lots of other work that Medicaid insured candidates have significantly lower access to living donor kidney transplant. However, if you see there on the right side of the screen, even after we made the stratification, Medicaid insurance was not a modifier for access to living donor transplant among African Americans. But even non-African American patients who had Medicaid had better access to transplant than African-American patients of either primary payer, either Medicaid or non-Medicaid primary payer. And then further, non-African-American candidates who had non-Medicaid payers had the best rates of living donor transplant. And this persisted even after adjusting for other candidate characteristics. So compared to African-American candidates who did not have Medicaid as a primary payer, non-African-American candidates on Medicaid had 1.6 times the rate of living donor transplant, and those not on Medicaid had 2.7 times. So really a dramatically large difference in access to living donor transplant. So then next we said, a lot of people, as you saw, the number 2 reason cited on that physician survey was lack of access to living donors. We said, okay, maybe a lot of these non-African American patients just happen to have a lot of living donors available that they'd kind of identified before initial activation. So to look at that as a potential explanation, we looked only at patients who were still on the wait list at least 2 years after they were initially activated on the wait list. With the thought we could kind of eliminate all those people who just came through the door with the donor. Again, we found that the same disparities we saw in the primary analysis persisted. And non-African American candidates, either with Medicaid insurance or non-Medicaid insurance, were significantly more likely to have access to living donor transplant. So then remember that the third most common reason cited was lack of access, the second most common reason cited was lack of access to living donors. And we thought, okay, maybe it's not an issue of early identification, but identification overall of eligible donors. We know that blood type varies a lot by race. So we thought maybe we can just restrict candidates with type O blood, and they will share the similar types of available donors, similar types of acceptable blood types that they can receive. But even then, in adjusted models, we saw the same exact types of disparities that we saw in the primary analysis. So this was not an explanation. Then finally, we said, okay, well, maybe blood type alone doesn't explain this. We know that family members share genetics, and there's a really big focus in the last decade or so on the impact of high-risk APOL1 genotypes on the high incidence of kidney disease in African Americans. So perhaps we can look at the types of donors that people do receive after they get a living donor transplant, with the idea that if it was just, for example, that African American patients have lower access to first-degree relatives who might share their APOL1 risk allele status, we'd expect kind of that chunk missing at any time point from listing to living kidney donation. So but as you can see here, no matter how long the period is between initial activation and transplant, the distribution of types of donors is the same, whether the recipient is African American or not African American. In other words, it's not just that one type of donor is missing, but rather there's no significantly different disparity in type of donor. Rather, it's that all types of donors across the board are decreased, suggesting it's not one type of donor that they lose access to, for example, due to genetics. This same theme is seen in preemptive waitlisting. So as I mentioned earlier, Black patients are less likely to get preemptive transplants, with a big contribution from early referral for preemptive evaluation and kind of preemptive waitlist placement. But as you can see here, again, race is a major modifier of other differences that we know impact preemptive waitlist status. So if we know that age, for example, really impacts the likelihood of you being placed in the waitlist preemptively. But as you can see here, when we look at gaps in access to preemptive waitlisting by age group, just like what we saw with living donor transplant and socioeconomic status, even the worst performing non-Black groups outperform Black groups. As you can see there, kind of the worst performing groups in terms of preemptive waitlisting among non-Black patients with kidney disease is those who are the youngest, 1839. They do dramatically better on getting to the waitlist preemptively than Black patients with age 65 plus. This persists even after adjusting for other candidate characteristics. So after adjusting for those types of things, the rate of preemptive evaluation or referral, so just getting to the door of the transplant center, is 37% less for African American candidates compared to white candidates. And as a result, as you can see here on the right side of the screen, that leads to a very large disparity in access to preemptive transplant that has not closed at all over the past 2 decades. As Dr. Poe said, there is some focus on GFR as a potential problem. And in fact, so you can see there on the left, it's true that those who do get referred preemptively have similar waitlisting GFRs, whether you're African American or not, suggesting that changing the threshold might have a small effect. And then when you look at the true problem there on the right side of the screen, it kind of really points out largely to the fact that the biggest issue is not getting referred later during the preemptive period because of a difference in estimated GFR, but rather these patients are not even getting referred at all until they're on dialysis. So complete lack of understanding and a lack of recognition and action in progressing these people towards the best available therapy. And really, no matter how you slice it, you see the same thing. So this is just other kind of slightly older data looking at other ways to just divide people by insurance type, poverty level, race, age, and no matter how you combine factors and limit to just one specific subgroup that might be very, very similar, you see that disparities in access to the waitlist persist. So if you go all the way to the bottom of this table, you can see this is just groups of patients who are on Medicare, who are less than 65, who live in areas with a high level of people who are below the poverty level. Even in this very, very specific subgroup, there is an over 1 year difference in observed median time to from dialysis to waitlisting. So really, it's hard to believe that these factors alone play a part. So then what we should be asking is, what is the potential mechanism, right? We can't talk about a finding without talking about mechanism of science. And I'd like to argue to you that one large part is provider to patient education. So as you know, dialysis centers have to inform instant dialysis patients of options for transplant within 45 days of initiating dialysis. We've seen in prior studies, so this is data from Maryland, specifically Baltimore and some 6 surrounding counties, that there's a big difference in whether patients report they've been educated and whether providers report they've educated those patients. So in this cohort, just over half the candidates and providers agreed that in 56% of cases, patients and provider agreed that this education was provided. However, in 28% of patients, the provider said, yes, I provided this education, but the patient said, no, I never got it. And the reason that's important, because if you look there at the right side of your screen, among those cases in which only the provider said they gave the education, but the patient did not receive it, kind of their rate of getting listed for transplant was the same as if neither the patient nor the provider said this education happened. This difference persisted after adjusting for other characteristics, as you can see here, and it was very large, threefold difference. And if I show you this same data again from USRDS data, just to make a quick point, again, that those who are not informed have lower access to the wait list and lower access to living kidney donation. But more importantly, in this study, they looked at factors associated with whether providers spend at least 20 minutes on kidney transplant education, which is kind of seems to be potentially one of the magic numbers in helping convert patients to become interested in transplant. You can see that one of the strongest factors associated with kind of not having that education provided is having a dialysis center that had over 50% of its patients with African American race. And again, this was true even in multivariable models. This effect size was bigger than any of the other ones in that multivariable model concerning patient population of that dialysis center, as you can see on the bottom. So before you become too despondent, it's important to know that things can change, right? So just quickly in 2 slides touch on the issue of directed donation. So historically, if we looked at non-directed donation, if we looked historically at non-directed living kidney donation, so patients who get a transplant from a living donor that was not directed towards any potential recipient. In the past, we saw large differences in the racial breakdown of recipients of those non-directed kidneys versus the rest of the wait list. With Caucasian patients or white patients, much more likely to get those non-directed kidneys compared to their representation on the wait list. And really, that screamed of potential center bias, right? So why were these specific patients getting selected for non-directed kidneys? However, the National Kidney Registry has done a really good job of identifying similar potential disparities. They have made a concerted effort in making sure that patients are well represented in chain end transplants, which usually are kind of at the end of a chain, the beneficiaries who might not have a donor that comes with them. And in fact, with those changes, the National Kidney Registry has seen that chain end transplant, so basically the ultimate recipient who benefits from the non-directed donation, have a similar racial breakdown as those rest of the wait list and deceased donor transplants in general. In fact, that disparity that you see in other National Kidney Registry chain transplants or other living donor or non-NKR KPDs, kidney pair donations, is totally obliterated when they make this change and focus on improving equity and access to chain end transplants. So sorry, I know that was fast because there was a lot to cover, but in conclusion, I just want, hopefully that I've convinced you that even after accounting for all kind of what we call systemic factors that contribute to racial disparities in access to transplant, these disparities still persist. And that suggests really that provider bias, either probably largely unconsciously, subconsciously, and affecting all other aspects of how we think of patients, is playing a role. And that addressing these disparities really requires recognition of this problem and conscious change. I'd just like to give a quick thanks to kind of the research group who worked on this work at Columbia. And once again, thank you to the Dalio Center and to the Berkson Institute for inviting me to share this work and speak on this topic.
Thank you very much, Dr. Husain, for a great presentation.